everyone. Welcome. Thank you so much for joining us. We're just going to give everyone a moment to get situated, and we're so excited to have tonight's case rounds with you. Perfect. I just see everyone is coming in. Find yourself somewhere comfortable to learn. Good evening. Maybe if everyone wants to put in the chat where they're joining from. I'm joining currently from Southern California. Good evening. We've got South Carolina, Ohio, Oregon, Vancouver, Texas, Japan. Oh my gosh, I love this. This is so exciting for me. New Jersey. They're going in so quickly. I love it. Welcome, everyone. This is so exciting. Thank you. Awesome. Well, my name is Madison Alig, and I am the Director of Clinical Relations at Radimal, and I'm really excited to kick off another round of Radimal Case Rounds together. At Radimal, we see some really cool and interesting radiology cases every day, and we love sharing some of the most interesting ones with all of you. Right tonight, you'll get to see both how our AI initial assessment, as well as our consultations from our board certified radiologist, can help with your clinical decisions. And if this is your first time experiencing Radimal, we are a leader in veterinary diagnostics. We have a web-based pack, a lot of AI tools, as well as board-certified specialist consultations to support your teams and get fast and reliable imaging. And then tonight, we're going to take kind of a moment to talk about some of your x-rays, the positioning and technique of those x-rays. And I'm really excited to introduce our expert for the evening, Dr. Kristen Fleming. She is our board-certified radiologist and one of the leaders on our medical community. She reads images for us almost every day, and she knows exactly how important positioning and technique can be in real-world practice. So before we dive in and I lend over to Kristen, if you have any questions about anything during tonight's webinar, please feel free to put them in the chat. I'll be watching that. And then after tonight's webinar, we'll be sending you all your CE certificates via email in the next few days. So you'll be able to watch out for those, as well as you'll have my information in case you don't receive that and need any additional support. Well, with all of that, thank you so much, and I'll bring it over to Kristen.
Thank you, Madison. Hi, everybody. I wasn't expecting so many, so we're going to try to make this very interactive. I have a couple of cases, as you all know, and I want to open up the Q&A chat as far as, if I have a screen with a question, you guys can enter into the chat and we'll go ahead and kind of pick an answer from there because we want to try to move through the cases as quickly as possible. But if you have a question, please feel free to shoot it in there, and Madison will try to help guide me, watch the monitor and the Q&A to answer your questions promptly. So let's get started here. Just to begin, I'm from Troy State originally, but did my veterinary medicine, thank you, Madison, at Tuskegee University, and then did my internship and my residency at Oregon State. So whoever's from Oregon, what's up? I usually read at night, so a lot of times you may not catch me in the daytime. Hey, Adrian. And when I have nighttime, a lot of the times we're getting emergency cases, so like hit by cars, or we can get, is the case surgical? So I try to pull some of those cases that I typically see at night, but we can also incorporate some cases that we may also get during the day. So just to begin, we're going to start with case number one. We have this beautiful 5-year-old husky. He was sideswiped by a car. Typical night for me. And so he's cranky, he has wounds on his back legs, and he's dyspneic. And so when we begin with the thorax, just to keep things very simple, if you will. So for our thorax, we tend to have a higher KVP and a lower MAS. As far as the abdomen, we do the opposite. And I always used to remember it in my residency as the abdomen hangs low, so we want a lower KVP compared to the thorax. So can anybody just throw out, I see Muhammad already did, can anybody just throw out some other things that they notice about what they see in the image? Like, what's your first initial impression? Yeah, go Beavers. As far as what's wrong with this patient. because remember, it's an emergent situation. Okay, so we have several people who are saying pneumothorax, and I agree with you there. Pneumomediastinum, increased densities, and the heart looks small. So what do you think about the technique on this image? Does everybody think it's okay, or maybe it could be improved? Is the positioning okay? You can just throw it in the chat and we'll go. Okay. Yeah, yep. I like all the answers. I like I like them all. So the ones that we're seeing is the front legs need to be pulled forward, right? So that is prime time. Like when it comes to positioning, let's move those front legs away or from the thorax so it's not superimposed with our structures that we're trying to assess. Someone mentioned a pneumo, or I guess a couple of people mentioned a pneumomediastinum, and I totally agree with you, but this was a tricky case at first because there are a couple of other images. Um, Patient will allow give. Yes, correct. Depending on your patient, if the patient is not sedated because it's dyspneic, then you try your best. I will always salute you because I've been there before when it's very difficult to get a patient to cooperate without sedation, but you do your best. But let's say we could sedate our patient. The pneumomediastinum, if you can see my mouse here, is right here. You can see this gas that's dorsal to the trachea and it extends along the dorsal margin of the trachea and ventral margin in the cervical region. So whoever saw that, great job. The pneumothorax is why our heart looks small and also why the heart is elevated. But because those legs are kind of superimposed with the cranial thoracic lungs, then we could miss the pattern that's actually within the cranial lung lobes. So this dog, I'm going to go to the next slide here. You can see on the left lateral view, we also have an increased amount of soft tissue within the cranial lungs. We don't want to miss that, and we don't want to just think over it because remember, our dog is dyspneic, and it could solely just be to yes, that's called superimposed. So the thoracic limbs are superimposed with the thoracic or the lungs, the cranial lungs. Um, and so what happens is you could actually miss contusions or pneumonia, which can happen, aspiration pneumonia, which can happen in these patients because things happen so suddenly. And so even in this left cranial lung, there are some faint air bronchograms, but the legs kind of interfere with us truly seeing them for what they are. I think on this left lateral view, this demonstrates the pneumomediastinum a lot better than on the right lateral view. You still have a pneumothorax, and again, we still have this increased density within the left and right cranial lung. So when we get to our VD view, we know the positioning is off. My guess is when I got these images, hey, the patient is probably dyspneic. They did not sedate. They did the best that they could. But even on these images, I can tell that there's a pneumothorax, right? Because we have the highlighting of the lungs around the periphery. And we still have this increased density, especially within the left cranial lung. So this is the report that was generated from this case. AI was able to pick up the pneumomediastinum and the pneumothorax, and the remaining, for the most part, intrathoracic structures are normal. And so when we get to my report, it missed the pattern within the cranial lungs because of the legs being superimposed. And I think that would help if you're needing a wet read in a fast case scenario, that would really help. So just as a reminder, make sure we don't have external body parts kind of superimposed with our thorax so that way we can help you faster in case, if this wasn't sent as a stat, you would have this turned around hopefully within 6 hours. So this was a good case of, again, kudos to those who picked up the pneumomediastinum. This was a very good case for is it real or is it not real? And I think that's really helpful when it comes to these emergent cases, especially like hit by cars. You have to assess and determine if that's truly a real finding that you need to report, we need to report on to let the clinician know, like, hey, you should really take a look at this. This is case, oh, sorry. Does anyone have any questions about that case? Okay. So DV versus VD for a dyspneic patient. I agree a DV would be better. But again, I'm unfortunately I wasn't in the clinic. I don't know how dyspneic is. Like, is the patient truly severely dyspneic that we probably shouldn't be attempting these images? Like we are on oxygen therapy, or is it something that is manageable if we can just get it done? I think that's determined case by case, honestly. I hope that answers your question. Okay. KVP versus thoracic, KVP and MAS for thoracic and abdominal radiographs. So the way I kind of tried to help myself remember it in my residency is when you have an abdomen, the abdomen hangs lower. Oh, you're welcome, Deborah. The abdomen hangs lower. So you would want a lower KVP for your abdominal studies and a higher MAS. So you're going to do the opposite versus the thorax is going to be higher than the abdomen. So I'm thinking of a potbelly dog. Sorry, that's my head. So for that case, your thorax is going to have a higher KVP, right? And you're going to have a lower MAS. Also, as a rule of thumb, there should be a technique chart somewhere in your clinic, and you should also measure if you're uncertain. Um, and I have a case at the near the end of the slideshow, which shows like a small microscopic puppy, and those can be very tricky. So we'll get to that too. But any other questions? Okay. Well, we are going to move on then to case number 2. This is our 13-year-old Jack Russell Terrier who has a grade 4 heart murmur. PMI is left side of the chest, which measured in February from a grade 2 to 3. But recently, the patient has been coughing in the last few days. And so these are our thoracic, or sorry, yes, these are our thoracic radiographs. I'm actually going to go through all the images first. Okay. And so can anyone just really quickly tell me if this is a thoracic study, what are the problems that you can notice here? Got it. Okay. Yep. Correct. All the things. Too much abdomen. Absolutely. Um, I'm a little bit of a stickler for this. Missed the cranial part. Yep. Correct. Um, so when we take a thoracic study, again, when we want to talk about strictly the thorax, KVP setting, and MAS compared to an abdomen, there's a big difference there. So collimation and proper technique play a huge role in this. And as far as this goes, collimating is also big because you can see the cranial aspect of the thorax is omitted. And so also the other thing I would try to do if this patient is not dyspneic is trying to take an inspiratory radiograph. And I know that is something that is, it depends on your patient, it's case by case, but those truly help. And you can also make sure you have the entire thorax in the image, especially if this is a dyspneic patient, a cardio patient. Those are things that will help us. So does anybody else notice any other thing? Okay, sorry, I'm trying to catch up in the chat. Um, anything else that you might notice? What about positioning? Vena cava large, okay. Loss of abdominal detail. Absolutely. So again, absolutely. As far as if it's a cardio case, would you want to include the trachea? Yeah, so that's why we want to strictly collimate this image to the thorax. No labels, it's twisted. You guys are nailing it. So good job to whoever mentioned the mass effect and the loss of detail. I think that was Christian. And so what you may or may not have caught was that there is a mass effect in the abdomen. So lucky for them, they included the abdomen or they knew the patient possibly had a history of a mass because there's a mass that's right here. And so it's not as well defined on this view, which is your left lateral. You can see it's kind of collimated out. And then when we get to the VD image, you can see there's a mass effect right here, right? So my recommendation for this case was one, let's say we collimated to the thorax, it's an inspiratory radiograph, we have awesome technique, but we happen to get a slight cranial portion of the abdomen and we have a concern for loss of detail. That's great. Now let's do a separate study of the abdomen instead of trying to shove it all on one cassette or one film, because now we are going to lose kind of contrast and detail between the thorax and the abdomen as far as, if we think there's concern. So moving on to our AI generated report. It picked up that there's some intervertebral disc disease, there's gastric distension, gastroenteritis was a concern, and spondylosis. So we have again, your positioning and your technique can help us better provide the report that you need. Because if you had gotten that report and it didn't mention mass and you continued on, then you would be like, oh my gosh, there's a mass and I didn't know about it. So versus my report, I also made a comment about the pulmonary vessels. I thought the dog was a little bronchial, but more so like old dog lungs, as we like to term it. But also that there's a mass in the peritoneal space. Now, if they were unaware that there is a mass, then that causes for some additional imaging and radiographs, further than radiographs. I would say we need to now move to ultrasound if that's what the clients want to pursue. But also, if they're going to pursue an ultrasound, you might as well acknowledge the fact that they probably should be seeing a cardiologist at some point to get baseline parameters of what's going on with the cardiovascular structures, structurally and functionally. Okay. Let me see. Oh, yes. So Christian, so catagrams. Um, love cats. I have two, but I understand how they are, right? They're their own people. So, with that being said, if it's the best that you can do, then go ahead and get it. I'm all for it. But if you have a calm cat who will actually be on the table, let you collimate to just the thorax, not dyspneic, then take strictly a thoracic radiograph. And again, if it's strictly for the abdomen, take strictly an abdominal radiograph. Pediatric cases are usually a little tricky because they're so small. And most times when I see them, I'm actually asking about, like, unfortunately, like human anatomy in the beam because, you're trying to hold this patient. So again, sedation can also help you with that. Um, I don't know. Honestly, I don't know. As far as Radimal and Signal Pet, I would defer to Madison. Maybe she could help you with that. I strictly worked with Radimal on these cases to kind of see, and I'm used to Radimal as far as like how AI is moving and functioning. And I can also say too, if AI picks up something that I don't, I would say, let me go back and check it out. And then I could say, okay, I can see how AI thought that was something, but now I can make a comment about it and say, I don't see this, right? So that's also another benefit of the AI system working to our favor. Um, any questions in regards to this case before we go on? You're welcome to the next case. Okay. So pediatric cases. We're gonna get to a case. So I actually want to hold on, but we're gonna get to a case. As far as pediatric cases, depending on your patient, your breed, your species, if you can collimate, I'm always going to encourage you to collimate. If you can sedate, I'm always going to encourage you to sedate, depending on the age of the patient. But if that's not possible, then I would say get what you can get, especially depending on what you need. Oh, okay. I'm catching up. All right, so we're moving on to case three. Anyone who has a Doberman, hats off. I just got mine. I am in the learning phase. So this is a 9-year-old spayed female Doberman pinscher who is persistent worsening right forelimb lameness. I wish I knew the clinic that submitted this because they did a fantastic job. Was seen a couple of weeks ago and prescribed carprofen for the lameness. Slight improvement, but has now worsened. Now is non-weight bearing lame on that right forelimb. And so for the physical exam findings, we have pain on direct palpation of the proximal right humerus and extension of the elbow. So this is what I originally got, right? And I want to hear the crowd give us their thoughts as far as what they see is going on. Mind you, we have pain in the right thoracic limb. Um, right, Rachel, agree. It's not the leg at all. And that's a funny looking elbow, right? So this to me, like when I first got this, I was like, oh my goodness, please let there be some additional images because, right, Adrian, hey girl, hey. Um, I was like, this is gonna be very challenging for me, right? Right, where is the leg? I didn't say that, but I want to commend this clinic so much for what they did next. So on this image, if you look here at this right humerus, this is not completely normal. There's cortical thinning and there's actually like loss kind of on this lateral aspect of the cortical medullary distinction. And if we look really, really close, we could say like, So this is something that I tell the residents. If it makes you question it, then maybe we should be doing collimated images to that region so we can get an assurance that there's no question about it, it's real or it's not real, right? So thank goodness this clinic actually went and did collimated radiographs, and I'm so glad they did because they did a fantastic job for shoulder, elbow. And so they actually did a comparison study, which is even smarter. But they did the left shoulder and the left elbow. But you can also see here, this proximal right humerus is not normal, right? We also have some periosteal response, again, the cortical thinning. And right in here, we kind of lose that cortical medullary distinction. So when we get to the right, we can see that there's a problem. There's a larger problem than what we want to actually, want to see as far as on that VD view of the neck. I understand where the clinic was coming from because of the breed. They were probably worried about wobblers, right? But they did their due diligence and then did collimated and comparison radiographs, which helped me tons because I was like, is that real? It might be real. So this solidified it for me and said, hey, I have an aggressive bone lesion of the proximal right humerus, right? And I also have some OA centered at the right elbow joint. Um, the other thing is once we have an aggressive lesion, I'm always going to recommend to you, and I think all my other colleagues are always going to do it too, is that we then need to pursue 3-view thoracic radiographs to rule out metastatic disease, right? And so here's our AI report. So AI immediately picked up on the aggressive bone lesion, which was great because they had the additional images. If you look at the detailed findings for AI for the aggressive lesion, none of them are picked up on those images of the neck, right? So again, your positioning and your collimation make a huge difference. Um, and then they thought there was also some shoulder OA and some elbow OA, right? So on my report, though, of course, I had to describe more, but we did get thorax in there. So I made sure to make a comment about the thoracic radiographs because that's what they want to know. If they feel like if there is an aggressive lesion and the thorax is in there, it has to be read, right? Like we want to make sure. But still, you need collimated or dedicated radiographs to the thorax to have a full assessment for metastatic disease. Um, I don't have follow-up in any of these cases. I'm terribly sorry. But I think that was a good case as far as positioning. Technique, I wasn't so bothered by, but positioning, particularly for this case, because we had an aggressive lesion. Any questions before we go to the next case? All right, then I'm going to move on. This is case 4. This is a 6-year-old neutered. Oh, wait, we got a question. Dorsal extension of the neck and cranioventral extension on the limb would provide better isolation. Okay, so let's go back. Oh, Here we go. Excuse me, Megan, I agree with you. I have seen cases where we'll have shoulders kind of superimposed with one another or superimposed with the neck or superimposed with thorax. I think they still did a good job, but for a rule of thumb, if you are positioning a patient for a thoracic limb, extension of the limb away from the adjacent body structures would really be helpful so we don't get the superimposition and artifact that we could say, I don't know if that's real, if it's real or not, okay? Any other questions? All right, we're going to go back to our case 4. So this is a Shar-Pei who's lethargic with excessive panting, has decreased appetite, occasional gagging at home, and then has a fever of 103.5, dehydrated, and has peripheral lymphadenopathy. So on the initial radiographs, I'm going to go through those images for you. That's your left lateral, and then that's your VD. So what are your thoughts as far as positioning and technique? Is it okay? Could it be improved? Or also, what are some things that you see? Yep. Originally, when I heard about this case, I was like, this dog has to have Shar-Pei fever. I jumped the gun. Yeah, a little too much abdomen. I agree. It could be collimated. Um, Not focused. Yep. Totally collimated. I agree. I typically like to go probably to, I would say L2 when I have to collimate because I want to get the most dorsal aspect of those caudal lungs. But if it's a deep chested dog, sometimes you have to take multiple images just to get all of the thorax or all of the abdomen. It really, again, depends on the patient. The technique, I think, could be a little bit better. I'm not going to harp on it too much on this case, only because I think if they had set the KVP and the MAS to a range that would be appropriate for the thorax, it would be spot on, but it's not terrible. Um, yeah, that's why I said the exposure, it's not terrible because I still have enough information where I don't think this is a non-diagnostic imaging. Okay. So that's the thing too. Like if you have a technique that's non-diagnostic by hands down, just try to repeat it, you know, maybe blastospondylosis. Yeah. Yep. Right. Because we're all trying to think of things that could cause this patient to be pyrexic. Spinalitis. Okay. So one of the things that caught my eye on this case is, and I think I only really see it on this right lateral view, is that there's, I call it a backpack or a hump. I won't call it a backpack, but it's a hump right here dorsal to the carina. And so that gave me really pause. Like, does this dog have tracheobronchial lymphadenopathy? And not to mention, as we go through the other images, the lungs have somewhat of a nodular appearance. So whoever said blasto, neoplasia versus pneumonia, you guys are like, I would totally put that in the wheelhouse for this. Um, as far as tracheal deviation, I would be cautious because if the patient is not positioned correctly, our trachea can look a little bit more elevated than normal. Same thing with the cardiac silhouette, and that's another thing I touch on. So, like when we have expiratory radiographs, everything in the thorax gets squished together. So the heart looks like it could be larger than it normally is. We may not be able to make out the caudal vena cava as well. We may not be able to see the apex as well either. So again, inspiratory radiographs truly, truly help with those things. And the other thing that I picked up on this case, like I looked at, because they included the cranial abdomen, we're going to read all of it, you know, yeah, especially if your head is positioned too high, that can also elevate, and positioning again, that can cause some artifact in our imaging. But when I looked at the right lateral view, it looked like the cranial abdominal serosal detail was a little bit reduced, especially caudal to the stomach. So right in here, it just looked a little bit reduced. So again, things that make me say, this would need sole like abdominal imaging compared to my thorax. And this is why contrast and detail are going to make a big difference when it comes to the lungs versus soft tissue. So going on to that left lateral view, I still have loss of detail there. As far as splenomegaly, I'm not going to call splenomegaly just for certain yet because I still have the superimposition of the GI tract. What I see here is a splenic tail kind of superimposed then into the small intestinal segments, which are gas distended. So we're also rotated. If you look at the ribs, you can tell that this patient is rotated. Okay. So here we're also still rotated. So again, if that's the only imaging I have, and I would say, hey, there could be concern for splenomegaly, I would say either ultrasound this patient or do dedicated abdominal radiographs to do further investigation because you also have loss of serosal detail, right? Um, and then here on this left lateral view, does anybody or can anybody see the pulmonary pattern that's going on in this right middle lung? I'll wait for everybody. All right. So in that right middle lung, we have an alveolar pattern. I think it's a little bit more interstitial, Christian, I'm so sorry. Christian, more cranial, but then as we get into this region where it's also kind of superimposed with that diaphragm and liver, it becomes a little bit more alveolar. And so even here, I still see like a nodular pattern, and we also have an increased amount of soft tissue that's superimposed with that right middle lung region and the right caudal lung. So when we get to our generated report, it mentions interstitial bronchopneumonia, right? Because it's that right middle lung, we have a dependent pattern with increased soft tissue, and then it also picked up a bronchial pattern. So again, it totally missed that tracheobronchial lymphadenopathy, and I think a lot of that can be helped with positioning and again, our technique, right? This dog unfortunately was rotated on both lateral images, and the tracheobronchial lymph nodes, they are so finicky. I think sometimes, like, unless they're like a huge semi truck, if your patient isn't positioned just correctly, it can be superimposed with adjacent soft tissue structures. So I did not read this case, but I thought the radiologist who read it named Meg, she did a fantastic job. Thank you, Christian. She mentions hypovolemia. There's a nodular pattern within the lungs. There's a thoracic lymph node, which is that the tracheobronchial lymphadenopathy, and then a mass within the peritoneal space. And I think where she's going with that is that cranial increase of soft tissue caudal to the stomach. So on this VD view, I think it might be a little bit better. Oh, it's cut off. So right here, it's just cut off just a little bit. But if you go to the AI report or her report, you can see that there's this soft tissue mass effect here within the cranial abdomen. And that's also still that loss of serosal detail. So again, we're going to want to do some additional imaging. So let's say this is a case that you have in the clinic and you took the radiographs, you're waiting on the report. You could at least tell the client like, hey, I think we have some pulmonary infiltrates here and I'm concerned about. Okay, I'm gonna get back to you, Liam. And I'm concerned about tracheobronchial lymphadenopathy. Let's wait to see back, but I also have loss of serosal detail. We might want to pursue some additional imaging. So let's see, case 2 and case 4, this is from Liam. We're both initially focused on the thorax, but because the abdomen was included as well, something suspicious was seen there. Is it therefore wise to just do thorax and abdomen views regardless, even if the primary concern is one or the other? I would say no, because remember, we're also exposing our patient to um, additional radiation. So if the primary concern is a thoracic limb, do your thoracic limb. If the primary concern is a thorax, do your thorax. Now there are our older patients, we'll put them in a category for just a hot second. Our older patients who come in with more comorbidities, so if this dog is known to have, I've seen them before, we get a case, dog is dyspneic, known to have a perianal mass, right? So they want to do staging. So they'll do thorax and abdomen. Yes, correct, Elizabeth. And also exposing your staff and you to additional radiation. That's why we're harping so much on sedating our patients so we're not in the room with those patients. But back to Liam's question. So in those cases where you have, multiple problems, if you will, I still think the best solution is to do collimated or dedicated radiographs to that specific area, move on to your next area, right? If you have a smaller patient and that's not possible, dogogram or catagram is going to have to do, especially depending on how your patient is responding on the table. If the patient is dyspneic, get what you can get because that may be the only time you can image the patient. And so any questions again? Oh, I have a specific question and it's somehow related. I passed my NAVLE. Congrats. Waiting for CPE. I want a rock solid information about how to get through radiology station. Any book? Um, I don't know who that's from. More collimation, less scatter, yes, and spondylosis, Ricardo. But as far as textbooks, so one that I recommend for my students back at Oregon, I'm trying to think of the name of it, but it's by Ruth Dennis. And it is a small book. It's purple. I'm going to be so embarrassed, but I'm going to show you guys because I actually have it. It stays, I used to joke and I say, oh, it stays next to my bed because I literally would pick it up for just anything that I needed a quick perusement through. Okay. It is called Handbook of Small Animal Radiology and Ultrasound. This is so old, okay, that the cover is off. Don't judge me. We listen and we don't judge, okay? So I use this book for like everything. And the reason I like it is because it goes system by system as far as like aggressive lesion versus non-aggressive. It goes through thoracic patterns. It goes through abdominal technique. And so it's not a hefty book. And so I use this Ruth Dennis, I'm so sorry. Dennis. Let me see. Guys, don't judge me. My book has seen better days, but that is it's the radiology handbook, okay? This book I absolutely love. Of course, I have Thrall. But those are the main two books that I typically will run to when I was like, is this, something that maybe I missed? But I absolutely love this book. I found it I did, Adrian, I did. I got the best use out of this book. I flipped all the pages. It's a great book. But if there are no more questions, I'm going to move on to the next case. This is the one I was telling you about, the puppy. Okay, so this can be as interactive as you need to. Case 5, this is a 2-month-old corgi. Started limping around 10:30 a.m. this morning after playing at the dog park. So this is what I have. What are your thoughts on this? Straight off, like just you hit me and we'll go from there. Broken, absolutely. Yep. The book's name is called Handbook of Small Animal Radiology and Ultrasound. Holly, excellent. Burnt image. Like, that's my big thing. Thank you, Madison. Yeah, so the big things are this is highly overexposed, right? And I'm not going to harp on collimation because this dog is probably itty bitty. It's a 2-month-old corgi. And then also that there's a fracture. So same thing that I get, like not labeled, absolutely. Same thing that I get like in those hit by car cases. Like I want to give you as much information as possible. Okay, wait a minute. We got two questions. If the exposure is so high, why is the background so gray and not black? So on my screen, that's a little bit much, but it's called planking. So you have so much scatter radiation that it's blackening everything else because the image is overexposed given the age. Okay, would you consider a spiral fracture would need an ortho for repair? Pelvic fracture, growth plates, finger. Yeah, we've got things. Yep, you guys are nailing it. That is a hand at the very ventral. This is a finger, person's finger, probably right here, but that's fine. We're not going to judge people. Um, so I had this case in particular, and I trauma cases, I have to scrutinize them. I'm a forensics junkie. So I try to look at so many things and I might even overanalyze, right? Um, so hands down, there's a fracture. I'm glad we caught the fracture, right? But the fracture is not as well imaged as it could be. But Adrian, that's where I'm going with the growth plates. So when I got this case, I couldn't see where my apophysis was, right? So I can't tell them if this thing is also avulsed or it's fractured. It's completely gone. Like I can't see it. It's superimposed with the preputial soft tissues, plus my adjacent soft tissues are overexposed. So for me, this is a small dog. We would definitely have to tailor our technique much, much better, right? We don't, Salter Harris, I think that's type 5. Right. But so here's the thing. Somebody asked about a ortho repair or ortho consult versus, I think it was an ortho consult. I'm going through all the questions. So here's my thing. If this fracture involves the growth plates, send it to an orthopedic specialist, in my opinion, right? Because, and again, I know there's also financial constraints. You work with your client as best you can. But when the growth plate is involved, I think that's when ortho should definitely be involved. And I can't tell them the most distal extent of that fracture if it's extending into the distal growth plate, right? The other thing I can't tell them again is about the apophysis. Is it also avulsed? I can't tell if there's soft tissue thickening. I believe there's soft tissue thickening, right? But I can't assess the soft tissues thoroughly. So this was a hard one. And again, I'm not trying to judge the clinic whatsoever because I think with such a small patient, they can be so tricky, especially when it comes to sedating and positioning and technique. But if there was an opportunity to repeat an image, this is one that I would consider because now we're talking about, I think of it like a ripple effect because what's our next best step is going to be hard if we don't have all the facts in front of us. And so Adrian said, would you change the technique? I definitely would. So this is going to be a smaller area. So we probably want to stick to something less than our thoracic settings, right? Technique charts probably aren't set for patients that size, best to treat like a cat. Christian, exactly. And also the thing to remember is how small this patient is, right? So for example, the knee, if you will, the stifle is superimposed with the abdomen, the prepuce. Those are things that could be tricky because you can't put your hands in the primary beam, possibly laser therapy, like back to the laser beam, back to the hands in the beam. But you want to make sure that you are safe, your patient is safe, but you're getting as much out of these radiographs as possible. So if possible, what I would recommend is trying to collimate as much of the leg as possible, right? And for a patient this small, you could also consider using a plate if there are still plates out there. So if you have a plate, that might be better because you can use the grid, which will help with some of that scatter. But again, collimating to our problematic area as best as possible and using the appropriate technique, that's what's going to help. I'm sorry. So Michelle says sometimes dental x-rays are better for tiny legs. Would Radimal accept that? I won't say we won't accept images, but I think that again, if that's your best technique and you're using a plate, especially for a smaller patient, then I would say we can always give it a shot and see what we can see. But in the event that it is non-diagnostic, I would say let's try to shoot again. Christian says, in this case, would you take your KVP MAS, or given that it's a bone versus abdomen or thorax, when we switched from regular film plates to digital, we lost a lot of detail when looking at extremities and birds. Yeah. All right, so I'm going to take Christian first. So with that, I would treat this as a smaller, you could use a dental setting, you could use a setting that's lower than the thorax, because this is not that large. And we usually say for patients under 15 pounds, we want to stick to a certain range. So I gave us the rough, I believe I said at the beginning, the rough ballpark for thorax, 80 to 120 kVp. And then the MAS between 1 and 5. So for this case, you probably want to bump it down, or sorry, bump the kVp higher, but bump your MAS down a little bit, because you're dealing with such a small area that you're focusing on, right? I'm sorry, Heather. If you frog leg the leg on top and rotate the pelvis dorsally, you will have left abdomen. True. So I I like trying, right, without overexposing my patient to excessive radiation. So you can do an open leg, which would then kind of rotate the pelvis, right, and also try to get a better image of the stifle and that proximal tibia without it being superimposed. Um, yeah, so the open leg is more of an oblique view. Liam, I'm going to come back to you. And so what needs to happen then is, if you're still doing that, you still have to adjust for the soft tissue component. It's easy for us to see the bone problem, but we also have to address the soft tissue component. And so Liam says, I'm a very new veterinarian. I never dealt with something like this severe before. Is there concern for making the tibial fracture worse by changing position? Well, Liam, let's say this. If you submitted this and you say, hey, there's only this tibial fracture, but you've missed a pelvic fracture, that's a bigger problem, right? Because we've now addressed one thing and not another thing. So again, you want your images to be as thorough as possible. I always say orthogonal images if possible, which means you can do an open leg VD, which has the pelvis centered, and it can also go down to the stifles. I would not try to probably read the tibia if it's going to be collimated to just the pelvis. But if you're going to have your lateral, you may want to do a lateral, open leg lateral or oblique with the abdomen kind of out of the way, and it kind of pushes the prepuce out of the way too, so we're not superimposed. The best way to remember it is, if it's skin to skin touching, then there's going to be superimposition and there's going to be more detail superimposed or on top of one another, which can kind of blur or obscure what we're trying to look at. Thanks. You guys are keeping up in the chat faster than I can. Yes. And again, sedation. So Liam, sedating this patient, that is a case by case call. If you are worried that this patient is too young to sedate and this is the best that you can do, then I would say get some analgesics on board, and then try, once the patient has settled down, to try again. Because again, orthogonal radiographs will kind of help. Like right now, we've only addressed the tibia. We haven't really addressed the fibula. We haven't addressed the other back leg. We haven't addressed the apophysis, the stifle, digits, pelvis. We've not done any of that, right? So my concern for this case when I originally got it was, again, the apophysis. I don't know if it's avulsed, if it's intact. I can't see it. And also, what is the most distal extent of that fracture if the growth plate is involved, to better help in guiding what your next best step would be. So here's our AI report. Normal. That is a huge flag for me, right? Because we know it's not normal, but because of our technique, this is what our AI generated. So this, I don't believe, was a stat case. So if you had this and you did a non-stat and you said, hey, I got my analgesics on board, let me try to repeat images and then resubmit them, then that would be a better solution, because it's going to be very different from AI and a specialist report. So I was able to pick up the tibial fracture just as you guys did, which was great. But I made quite a bit of commentary on the tibia apophysis and also the distal extent of that fracture. So again, you guys, hey, Durandal, you guys kind of keep that in mind when you are looking at these images and kind of assessing, like, is this good enough to send out for a diagnostic review? If not, then I need to go ahead and maybe try some different positioning. In these cases, if this was a hit by car and again, it's the tibia, we see it, I definitely want to make sure I get pelvis, stifles, and most of the legs in an image. Um, but because this dog's history was dog park, it's a spiral fracture, and I still want to assess all of that limb. Okay. Does anybody, okay, so Hillary has a question. Why are the digital views showing all non-collimated areas showing direct hand exposure? Is this a collimating issue, or do all radiographic machines have this scatter and exposure? I wouldn't say all of them have that. We definitely, when I was at Oregon during my residency, we did not have that, but we also sedated just about every patient that was on the table. So I would say when it comes, we can go back to that lateral view. Okay, so for this, we would collimate tight. We want the limb as much as possible, and we're going to collimate very tight knit, right? And if the patient is sedated, that's your best bet because now your fingers, digits are not in the x-ray beam, and you can position your patient as possible, or you can even, depending on how sedate the patient is, you can use a restraining technique like a tethered cord or rope to kind of extend that leg even further away from the body if you can't get it kind of superimposed. Those are techniques that we've used in the past, but I would suggest with something that's fractured, make sure the patient is hugely sedated and then that you're not applying too much pressure on that leg to actually do more harm. Okay. Correct. This is not collimated. This is just cropped. Let me see. Stacy says a lot of times it has come down to machine setting or whether auto crops. Yes, there are auto settings. Trying to think back. Hillary, if your digital machine has settings, you can adjust them. And so Heather says, semi-related, for ortho images, do we need to always get the above and below joint concerning joint or focus on the joint itself? I'm going to say as a rule of thumb, always do a joint above and joint below. In this case, I think with the history, we have a good starting point. We know it's fractured, right? But because we can't see the joint below from overexposure and we can't really see the joint above because of superimposition, that's also another kind of needle that say like, hey, we should really re-image this. Our machine auto, okay, wait a minute. Let's see. Are there inexpensive types of foam you could recommend to help with positioning? I'm trying to think back. We had wedge foam. I don't really recall the name. I do apologize. We had wedges that we would use for our thorax cases, and sometimes we would use those for our legs. But most times, again, with sedated, they were restrained with tethered cord, especially if we were doing like a OFA hip study. But most times I'm really trying to think back. Most times we would use wedges, but I think even still in a patient this small, a wedge is not going to help because I've never seen a wedge that small. Um, Now, if you have a larger patient and you can pull it off, then I would say it's okay to give it a shot. Let me see. Sandbags. I think sandbags would be good for probably covering the abdomen if you still can't collimate any further, but it doesn't really do much for your technique. But even with gloves, there seems to be so much radiation outside the collimated area, almost as a direct beam because you sedated. We use sandbags, senior pets with no blood work. Pool noodle. Yep, I've seen pool noodles. Let me see. You guys have some good recommendations, Deborah. So using a trough. Okay. That's a really good question. So if this were our patient, this small patient, and we use a trough, I would say you can actually position the patient so the hips are off of the trough. So the back, abdomen are in the trough, pelvis out of the trough, which causes it to kind of dip down so we don't have that superimposition. One of the things to also keep in mind is when you're doing pelvic radiographs, you also have to think about the colon and the rectum having feces because that can also kind of blur our image. And then when it comes to, so once you get your pelvic view with the pelvis kind of dropped out of the trough and on the table, take your beam and kind of come down even far distal and now do your legs. Your legs are kind of going to just flop down. So like if this is our trough, our pelvis comes down, legs just kind of flop down. You can position them as need be, but again, make sure you have the right technique. How about the abdomen and thorax in a trough? Um, Let me see. I think for most of our cardio patients, we would use a trough if we could not get them like truly in our best position possible. But most times, even in smaller patients, I've seen some foam or noodles that acts as a trough so that we're not getting the superimposition of the trough to cause problems, especially if you have an older trough that has cracks in it. Let me see. Paint a picture for me, please. All right, let's try this, Elizabeth. How are you using pool noodles cut in half? Thanks in advance. Best to try and get straight images. Okay, you guys are commentating on this. Recommendations for fractures or with kittens. So I'm gonna treat a kitten the same as a puppy because they're very small. Um, if you have limb fractures, I think it's totally fine if you want to use a trough, but make sure the area that you're trying to image is outside of the trough. So it should lay flat. So let's say the kitten has a broken thoracic limb. Go ahead and put the thorax in the trough, but make sure the limb is out. So that way you're trying to get your patient as straight as possible. Again, totally that has to be sedated under sedation. And then you can try to stretch it as need be with the appropriate technique. If it's a pelvic limb, you could do the same thing I just told you with the pelvis. When it comes to thorax and abdomen in the trough, I usually don't have any problems that I question, is it real or not real? Sorry. But when it comes to those thoracic or those pelvic limbs, I tend to see the bottom of the trough kind of cut through the either the femurs or the tibias, and it kind of can get in the way if you're wondering if there's an additional fracture. Um, any other questions then? I'm just trying to make sure I'm keeping up with all you guys. Michelle, let's see. Without using troughs, would you recommend? So let me see. We have a debate over troughs. Most learned measured without, some learned with the trough thickness. I during residency and during vet school, I never learned to measure with the trough. I've always done without the trough. Sorry, I missed that question earlier. Um, Skull rad positioning. Okay, Rachel, I'm gonna get through these cases and I'm gonna come back to skull rad positioning. I will not forget because I actually enjoy reading skulls. All right, let's move on to case number 6. This is a 3-year-old spayed German Shepherd, right forelimb limping, started 2 weeks ago. And then the lameness initially showed improvement, but worsened after going for a run with the owner's husband on Friday. So this is our radiographs. Does anybody disagree with the technique or the positioning? Okay, someone commented overexposed, missing part of the left shoulder, full limb, shoulder. Christian says bicipital tenosynovitis. Should the shoulder be cut off or overexposed? Shoulder. All right. So hard to get proximal and distal leg with same settings. Okay. Carpus missing. Humerus looks shorter. All right. All good thoughts. So based on your physical exam findings, I think you can localize the site that's painful. So for example, if we're having pain that's within the shoulder region, then you want to focus more on the shoulder. And again, positioning your patient without that scapula, or as much as you can, the shoulder actually superimposed with the thorax or the neck, and try to also include your scapula. And then I think somebody mentioned today, as far as like the technique for the distal half of the limb versus the more proximal aspect. When it comes to that, you should still use your same setting, but I think you can collimate. Most times, if it's a small dog, you can get the entire limb in one image, but if it's a larger dog, you can tend to use you can do 2 separate images if the dog is that large, where you need to separate the images, but use the same technique. Okay, suggestive of inflammatory, bone degeneration, the center of point of interest, elbow. Yep, Mary. Mary, good job. Because if you pick up on this right and left elbow, you can see that there's a little, what I would call air gap or lucency here at the base of the anchineal process. So this dog also has UAP. Good job, Devon. Or sorry, I don't know if it's Devon or Devon. Um, and so when we get to our AI report, it's going to mention elbow degeneration because there is some degenerative OA changes, and then it also thought there was some soft tissue swelling. I didn't add in the it did include the carpi and manuses, but I did not include them on the screen. So here's one thing. If we are worried about this dog's elbow, I would collimate strictly into that elbow, and I would do a neutral lateral and a flex lateral because those are our techniques to kind of really depict UAP in these dogs. If the patient or the client or clinic said that they had some shoulder pain, then okay, now that we have this, we could also collimate down to the shoulder. So again, your physical exam is going to help us kind of narrow down where we need to focus our imaging on. And so just getting here. Again, things that you guys couldn't see, but we mentioned UAP. There's also some medial coronoid disease. Collimating in on that elbow would really help that stand out. And so again, one of the facets of elbow dysplasia is going to be medial coronoid disease, UAP, and DJD. So most times when ortho consults, they're going to want to know, are there degenerative changes that have also taken place with elbow dysplasia? And again, they're probably going to want to say that you want to do a CT for this dog. But again, as a starting point with the images collimated to the elbows, that would be really helpful for the elbow. Yeah. So think of it this way. You want to put your dog on the table and you want to do a neutral lateral. So the dog's arm is just laying there. And then you want to flex it because that's going to pick off that anchineal process so you can see it a lot better. Thank you, Hannah, for writing it down. Thank you, Liam. Any questions on that one before we move to our last case? All right. So we are on case 7. This is a 9-month-old female poodle, presents for inappetence, vomiting, diarrhea, and lethargy. I mean, yes, it's a real poodle. It's a real poodle. All right. So quick thoughts. Anybody. So we had lethargy and appetence. Is your initial to image the abdomen or the thorax? Right? But again, your physical exam is going to help you with that. So who's that? Hillary? I totally agree. We couldn't decide if we wanted full thorax or if we wanted full abdomen on this case, right? So in this case, I would say you've got GI symptoms. Let's start with the abdomen. Good job, Lillian. I would say strictly collimate to the abdomen. If this poodle is as small as what we're picturing, then we should be able to get the abdomen in one lateral image. So, okay, let's see. Abdomen only needed. Yep, I agree. I don't know what they were. So Christian, I'm not sure if they were concerned, like, could it be thorax? Could it be abdomen? So they did their kind of a dogogram as much as they could. But I would still recommend doing solely an abdomen first. Again, this is, my thoughts, not with my hands on the dog. So it says stomach looks off and loss of detail. I agree on loss of detail, but the patient is also really thin, right? Like this is an overexposed image, and you can tell by looking here in this inguinal region, our soft tissues are black in a sense, but you can also see like the soft tissues along the spinous processes are kind of dipping in. So this is a thin patient. And so with thin patients, it can also cause our detail to be reduced and not have like fluid or pancreatitis in a sense. But I think it's touch and go with a dog who has GI symptoms. And also we can't, it's kind of tricky if there's true loss of detail versus the patient is solely just thin. Um, Concerns for constipation. So with that amount of gas, I wouldn't think there's constipation, and there's a small amount of feces within the descending colon. So again, and rectum. So I'm not concerned about constipation on this one. Um, yep, I agree, Ricardo. So these are the other additional images. They included the abdomen, cranial abdomen, and they split it into two, right? And so this is our left lateral abdomen, if you will. Um, Let me see. So there's a concern for a foreign body. We're gonna rain check that one. I haven't forgotten about skull radiographs. Um, Two populations of small intestines. Okay, I like where you're going. So you're also in the boat for a foreign body. Anybody else? All right. So For those that came up with the two populations of small intestines, I think you are spot on. Oh, you want to see a VD? My fault. This is first VD and then your second VD. And so my concern is that there is a foreign body because I agree there's two populations of small intestines. So my other concern is like when I look at these generally, yeah, the patient is skinny. When I look at these generally, like I can give the colon as much gas as it wants, and not be bothered by it. But once I start to see that there's too many gas distended small intestines, it kind of perks my interest and I say, do you have two populations of small intestine? Because if you are, now I'm on the hunt for a foreign body or some sort of obstructive process like an intussusception. Yeah, mangoes. Yeah, I had recently had that happen with mangoes and a foreign body. So we're going to go to our AI report here. And AI was considering a small intestinal mechanical obstruction as well, gastric distension, gastroenteritis, and hypovolemia. And then my report was also, the heart looked a little bit small, but it's a small patient. We're also rotated, but I needed to make a comment about it. So hypovolemia and also a small intestinal foreign body with a mechanical obstruction and possibly some colitis as well. I'm going to go back to this image here. We have a lot of frothy fluid kind of in that mid-abdomen. Yeah, avocado pits are infamous. And so we continue to see kind of this heterogeneous pattern there. And that's what kind of struck my attention. I was like, this thing hasn't moved. It still looks heterogeneous. What's going on in there? And it doesn't help that the patient is so thin as well because we're kind of losing some of our detail. Peach pits will do it too. Um, oh, as far as a perforation. So look at all of your images before we jump to a perf. And the reason I say that is I originally, when I looked at these images on this right lateral view, I was concerned that there was gas outside of the small intestines, right? Because I saw all these little small gas foci. But when we got to our left lateral view, I really just see fat and soft tissue. Yeah, exactly. Because remember, images are kind of two-dimensional, so we kind of have to use it in our head or make it 3D in our head. So the next thing, when I get to this left lateral view, I don't see any free gas that gave me concern to say this is a perf, right? I still think the patient needs surgery, right? But not a perf, right? Which we have more surgery, right, than what we were thinking. Um, and so we're going to get back to our report here. And so we recommended surgery for this case. Again, I don't have an outcome, so I don't know what the foreign body was. But what I typically like to do with patients who are, and I will say this dog presented again for vomiting diarrhea, they image the thorax. So make sure we're going to comment on the thorax. If you guys have included the thorax, make sure you comment and look for aspiration pneumonia in these vomiting cases. If you don't see vomiting or if you don't see aspiration pneumonia, then make sure you keep an eye on your patient to make sure they don't develop coughing or respiratory symptoms. I believe that's our last case. Thank you guys so much for joining. No, you're right, skull radiographs. I'm so sorry. Skull radiographs. When it comes to skull radiographs, I'm a little bit of stickler of that. I like a direct lateral. So no oblique. Like if you're going to do a lateral, it's a true lateral, which means frontal sinuses. These are our frontal sinuses. And when you turn them on their side, they should look like this on your image. Okay. Nasal passages should look like this on your image. It should be gas on gas, not kind of rotated. Once you get that lateral image, you're welcome, Adrian. Love you. Once you get that lateral image, then you can work on your oblique views if you're worried about an oral issue, right? Because we want to oblique to get the superimposition away from what we're looking at. Versus if you want to look at bulla or you want to look at the back of the mouth, then we can do open mouth views. And for those, I highly, highly recommend using the TVP website because they specifically have instruction for or direction for skull radiographs. All right, cool. Thanks, Adrian. Oh no, wait, quickly go back to case 5. If you know the elbow is your point of concern and wanted to collimate to that, would you still try to include the joint above and below? Good question. I think it's fair that you have a lame dog if your concern is the elbow, right? You image the elbow, great. You have an answer as far as what the problem is. But if you have shoulder pain, I think that still would cause you to say, hey, let me image the shoulder. As far as joint above and below, if they're going to proceed with CT, I think they're also going to include joint above and below. So I wouldn't even go that route. But okay. Oh, you're welcome. Okay, somebody asked me for the TVP website. So TVP, I believe if you type in TVP skull radiographs or skull x-rays, it should pop up. It's an article, and so they give you direction on how to position your patient. All right, you guys are so welcome. You're welcome, Christian. Awesome. All right, Madison, it's all yours.
Oh my gosh, this was so incredible. Thank you so much. Like I said from the beginning, she's a rock star. You've all got to experience that. She's here supporting patient care every day. If you all have any questions about anything Radimal, please feel free to scan that QR. You'll get your first 5 reports, maybe with Kristen, for free. What could be better? And then any other questions, I'm here to support you all. You will receive your CE certificate in the next few days via email. Thank you. Oh, this is wonderful. Thank you all so much. Any other questions, don't hesitate to reach out. My email address will be put in the chat as well, and I'm happy to chat with anyone. Thank you all.
Have a good
Have
night,
a wonderful
everyone. Bye.
evening. Good night.